There are three main topics in this symposium. The first one is the topic of stereoelectroencephalography, what we call sEEG, which is methodology to implant electrodes in the brain in those patients in whom epilepsy is very difficult to localize in what we call using non-invasive methods. The second part is an update, an in-depth update about the state of the art in pre-surgical evaluation and surgical management of patients with medically intractable pharmacoresistant epilepsy. And the third part, it is looking forward at what's new in anti-seizure medication treatment, what's new in genetics and gene therapy, what's new in digital post-processing of the data, and how can artificial intelligence help us as a community in approaching patients with epilepsy in general and patients with medically intractable epilepsy in particular.
Oh, it's very cool, very interactive. Obviously, a couple different levels. We're getting some things from the past. We're learning some new things now, and obviously looking towards the future as well. So I'm also curious from your perspective, you kind of alluded to at the beginning of our conversation that it's been some time since our last symposium, and there's sort of been a good amount that's changed. So in your opinion, what are some of the biggest changes that you've seen from epilepsy surgery and what we've started to learn more about what you've seen from the research just in general? So talk a little bit about what you've seen from the change across from your colleagues and just, the field in general.
Yes, I think the field of epilepsy, like many fields in medicine, continues to evolve with time. So if I want to reflect a little bit and think about over the last 5 years, what has changed? So first, from the sEEG standpoint, we know much more now about the indications for the sEEG implantation. Who are those patients who can benefit the most? We know much more now about new indications for sEEG. For example, there were some pathologies in the past where we did not implant. Now we are implanting. An example would be periventricular nodular heterotopia. These nodules around the ventricles. They were being implanted like maybe 10, 15 years ago, but over the last 5 to 10 years, there has been new data showing that if you combine the assessment of the patient, combine MRI, PET scan, ictospect, MEG, and use all of this information to implant the sEEG, the yield of the sEEG in localizing the focus is much higher. Over the last 5 years, maybe 10 years here, we've been using less invasive methodology to ablate or to burn the foci, the focus of the epileptic areas. And for a pathology like periventricular nodular heterotopia or PVN, this pathology you can do in laser, using laser probe, you can do ablation of these ganglia or nuclei. That's very new and it's much less invasive than opening brain and thinking about going to these deep inside the brain and taking these nodules is not a very safe way. So this is another example of how the new indications of sEEG have been much better selected and much better validated since over the last 10 years, for example. Now, looking at epilepsy surgery continues to evolve. And see, in the same way of sEEG, but in particular, we're becoming less invasive in epilepsy surgery. We're doing more of the ablation, in particular using laser probes, if we figure out a very focal area in the brain. We are doing more of this. And then we are doing more epilepsy surgery without sEEG. For example, cases where we do have a small dysplasia in the depths of a sulcus, what we call depth of sulcus dysplasia. 10 years ago, we used to implant all of these patients with electrodes. Now, we do intraoperative mapping and the surgical resection with almost like previously unheard of outcome of 90%, almost 90% of these patients will become seizure-free. So these are from the surgical standpoint. From the new things, what has happened, I think the more exciting thing that has not been validated yet, but it's gonna be hopefully the next 5 to 10 years, is gonna be more and more used, and hopefully some indications much better outlined and validated will be what we call gene therapy. Genetic therapy is where I think the more exciting part of the epilepsy treatment in general, and in particular, treating these patients with difficult to control seizures.